เห็นเห็นหน้าจอสไลด์ไหมคะ
เห็นค่ะ
ขอบคุณมากค่ะที่ตอบโอเคถ้างั้นเริ่มนะคะ Okay, the lecture is about the about the oral lesion that your previous lecture maybe mentioned about many type of the lesion. But today I gather the lesions that has the characters composed of the red character and the white character. There are some lesion show the mainly the red color, but some show mainly the white color, and some show mixing together with the red and white. For sure, these lesions may be another lecture, maybe redundant, speak about the same name of the lesion, but in the other topics like vesiculobullous or something like that, because some lesion has many or various characters. However, today's lecture focus on the red and the white character of the lesion. Okay, so these are still important for the content that we just use to learn only. For the objective, every lecture show we need you to know or have a goal for something. Today's lecture, I would like you to know or can explain about the causes, pathogenesis, clinical characteristics, investigations, diagnosis, and treatment of the red and white lesions at oral and maxillofacial regions. And for sure, because many lesions has a similar character, so the generation of the differential diagnosis is also important. And finally, when you have a chance to start your clinic experience, I hope you to apply this knowledge from the theory to the clinical practice. Next, for the outline of the content, today is a big five outline about the normal group of the normal variations that show the character of the red and white. The next group, I will talk about the infectious lesions, and next about the non-keratotic white lesions. Another group are the keratotic white lesions with no increased potential for oral cancer. And the last group is very important because most of the patients come to you with the lesion or the pain or the burning sensation, worry about the oral ulcer or something like that. But in their mind, they will worry about this lesion or this mass or this ulcer is a oral cancer or not. Today, I will not talk about the oral cancer, but the last group we call the potentially pre-malignant oral epithelial lesion, or in abbreviation is a PPOEL. This is a group of previously named as a potentially malignant disorder or PMD. This is the most popular using name. This group, the earlier name also called as pre-malignant lesion, something like that. So that means this group, the lesion has a chance to turn into the oral cancer, but high chance, low chance is depend on the type of the lesion that I will explain later. Next one, in the group of the normal variations, I will talk about the leukoedema, vice omnivus, fordyce granule, linea ababaculis, and geographic tongue. For the infectious lesions, I will explain about the oral heli leukoplakia, oral candidiasis, and nasal or alveolar. Next group for non-choleratic white lesions. I will explain about the habitual cheek and lip biting, burns of the oral mucosa. For this group, the choleratic white lesions with no increased potential for oral cancer. That means you can see appearing character is a white lesion. But this group is not related or has no any chance to change to the oral cancer. So it's will explain about the friction keratosis and smoker keratosis. And the last one, that's the most important, the PPOEL group or PMD group. I will talk about leukoplakia, erythroplakia, tobacco-associated lesions, submucous fibrosis, actinic cheilitis, oral lichen planus, and oral lichenoid lesions. And finally, is a lupus erythematosus. Okay, I will start from the first group. That's this group of normal variations that I use to tell you that this group is not disease, but it's in the range of the normal. That means it looks a little different from general normal, but it has the variance, so we call normal variation. So this lecture about red and white, so I will talk about the normal version that has the character of the red and white. Okay, start with leukoedema. How about the leukoedema? If you see from the name, maybe you can guess like how about the leuko? What is the leuko meaning? And how about the edema meaning? The leuko mean
ขาว
white
ขาวกับบ
จะ
วม
ขาวขาวบวมเก่งมากนะอะไรขาวขาวบวมๆนะ leuko and edema. So from the name, if you can guess, you can match with the character that I will explain. The leuko and edema, that means the normal variation. First, I will explain again the normal the most character of normal variation is symmetrical appearance. Both sides look similar. Okay, so this leukoedema is appear on the both side of the in general is a buccal mucosa. It's appear on the buccal mucosa and white. And if you see leuko, it's white, but in clinical, it's not look like edema. It's like a only change the surface to the white color. It's like a filmy or milky white, like for example, เหมือนวุ้นมะพร้าวนะคะ like a coconut gelatin, like that. That's the character of the leukoedema. And most of the surface is smooth, but sometimes wrinkle or corrugate. So the picture upper picture is look a little wrinkle, but the lower look more smooth. And sometimes not only white, sometimes it reflect like a gray white. And when you see or notice about the border, it's like it's feel to the normal. You cannot see the sharp border. It's blend to the surrounding normal mucosa. When you want to prove that it's a leukoedema, you try to do stretching. The lower one, this is normal position, is look white, but when you try to stretch, the buccal mucosa is disappear, it show become to the pale pink color. To prove if it become like this, be sure that it's called leukoedema. Most of the cases appear in blacks and variable in whites, especially in African Americans people. So this is a reason why it's called leukoedema, because for the histology, it shows the intracellular edema of the spinal barrier. This is a cut point. It shows the intracellular edema. That's why they call leukoedema. Okay, because it's normal version, no limit with the malignant potential. Okay, for this one, anyone has questions for the leukoedema? If no, I will go to the white spot nevus. How about the meaning of white spot and nevus? Okay, anyone try to discuss together?
นี่วัดคือเป็นไฝป่ะคะแล้ว
เออ
ไว้
สปองสปองเออ
ฟองน้ำขาว
เป็นไฟด้วยเนาะจะไปกันได้ไหมโอเคลอง try to think about this and let's see what is it white spong and nevus. Okay, this white spong nevus is not look like any nevus, but I don't know why they call like this, but it's a genetic autosomal dominant. Okay, that means developmental anomaly. Okay, for the clinic, can you see it look like a white and spong, right? It's like a spongy surface of this example on the buccal mucosa. So because it's normal variation, so it's symmetrically apparent, asymptomatic, and because it's developmental, so it's appear early in typically before puberty. So when you ask the patient or you see the patient, when if they come earlier, most of them are teenager or young adult that will show this lesion because it's appear earlier and it look more white than previous lesion, right? Because it look more thick and rough surface. When you see white lesion in the oral mucosa, what should you do to try to do first?
Try to rub it off ป่ะครับ
Yes, what is the purpose that you want to rub it off? If it can be rubbed off, what is it? If it cannot be rubbed off, what is it? So you have to have these two ways in mind because some group of the lesion can be wiped off or rubbed off, but some cannot. But enough is not how to say 100% to say if rubbed off, it can say this lesion 100%, but just roughly discriminate. Which lesion that you can remember that it can be wiped off or rubbed off from your previous learning experience? You can give some example for wipe off or rub off lesion. Mấy cái này đọc lại mấy example of the lesion that can be wiped off. เช็ดออกได้จะไม่ชื่นกันเนาะแล้วกันต่อเดี๋ยวแค่รักษาตอบก่อนนะโอเคอาจจะตอบไม่ได้อาจจะถามยากไป Okay, for the lesion that can be wiped off, that means it's not come from the hyperkeratosis process, right? So maybe it's something that on top the surface of epithelium. Like for example, like a debris, or like you eat some food or some yogurt and it's still on top of the surface, it can be wiped off. And for the example of the lesion like a pseudomembranous candidiasis, because the candidiasis is a old growth on top of the surface of the epithelium. So if you try to wipe off with the gauze, that's not very easy to be wiped off, but it can be scraped. So maybe you apply to the group of the lesion. Now the lesion that come from the hyperkeratosis or hyper multiply of the epithelium surface. This is the meaning of the wipe off or not wipe off. I think that when you learn more and more lesion, you gradually understand. Okay, from the picture, when you see the white spot, it looks like a soft white, but it cannot be wiped off. And the surface show the fold or shaggy surface, and the common area is about mucosa. When you notice about the margin is blended to the surrounding epithelium or surrounding mucosa. It's not very sharp cut point of this margin. And the other layer at the tongue, vestibular mucosa, may be also evolved, but most common is buccal mucosa. Some cases show is involved entire of the oral mucosa. This is example for other tongue. This is white and the margin are blend to the oral mucosa. Because it's a white spongy one is a autosomal dominant with the keratin gene, so the extraoral lesion can also be detected, like a conjunctival mucosa, esophagus, and as well and vagina. So that means when you suspect about this one, maybe you can notice about like a change at the conjunctival mucosa as well. This is why they call white spot nevus. Sorry about that. Because the histology is lupus spot, right? It's a basket with appearance of the epithelial hyperplasia. Lupus spot, so it's called the white spot, but nevus, I'm not sure why it's called like this. And show the extensive hepatic degeneration, but no any dysplasia or inflammation. How to manage? Because of the normal variation, we just explain to the patient that it's just normal variation, it's not disease, no any treatment are needed. So to reassure, and the most important part of this was only one. We should talk about if patient can answer the positive family history, because it's a autosomal dominant, so some of the family of the patient may or should have this lesion, but maybe that patient know or not know, it's depends. But if he or she can report that, okay, my father, my grandfather, grandmother, or my parents also have this character as well, that means the positive confirmation that, oh, it's white stony was for sure. So you don't need to do anything. However, this white stony was look like some lesion that also important. Can someone try to help me to answer which lesion that is look like? When it show like this, it's like a white plaque and cannot be wiped off.
oral lichen planus หรือเปล่าคะ
Okay, oral lichen planus. Okay, one of them. มีอะไรไหมคะที่ขาวๆฟ้าๆ like a white plaque.
leukoplakia ครับ
Okay, because oral lichen planus can show like a plaque type, and you can also show like this. So if you are not sure and patient cannot report any family history positive, it's better to do the biopsy to confirm. Or if you misdiagnose, if it become the leukoplakia, the important are changed because if the leukoplakia is moved into the group of pre-malignant lesion or potentially malignant disorder, that has a chance to have a dysplasia or go to cancer. But West One was no anything really, really one with the oral cancer. So when you are not sure, the biopsy are the best choice to do. Okay, next one. Normal variation still. What is granules? I think this one most of you are already familiar. Heard it again and again because it's a sebaceous gland in the oral cavity, that means the ectopic sebaceous gland. Sebaceous gland that should stay only in the skin, but it appears in the mouth. They don't know why it appears in the mouth, but previously we tried to biopsy and show, oh, we just with sebaceous gland. So if you see this character and you are sure that for dice granule, you don't need to do any biopsy. The for dice granule, you have to start with F in the capital letter every time because name of the John Wilson for dice to talk about this one first. And most common it means that, but I think women also can be found about the for diagram as well. If you notice the sebaceous gland, it should show the white or a little yellowish color, and it's more. Each gland is more purple. It depends on maybe it appears small amount. Sometimes it appear a lot of small amount, and sometimes it appear all over or entire the mucosa. This is example of when they show or in the overall of the oral mucosa. The patient can feel like a roughness of the surface and just notice and just worry later. When they are young, maybe they didn't notice. Each apple, just each apple, is size of the diameter about 1 to 3 millimeters. But when it's packed or closely packed together, it looks like a huge area. But each one, we have to try to see is composed of small one of the apple of the for that brand. This is character. And sure is asymptomatic. Most common areas are buccal mucosa. And next one is a vermilion border or vermilion area. This is a common area. However, the other area like the right side of the tongue, Rhitomora pad, anterior tonsillar pillar, like this, also rarely or sometimes can be seen that for that granule located on this area as well. And they can gradually grow inside with age. However, it's not very big size. It's still in the size, I think about still 1 to 3 millimeters. But when you compare to oneself, it's a little gradually growth with the age change. And sure, there's no need for treatment. However, someone worry about when it appear on the vermilion zone or vermilion area. So, if this problem, you can maybe consult with the dermatologist to just for aesthetic reasons. Like maybe they can use the laser to remove or something like that. But if no any worry, just explain to the patient and observe. Okay. Is there any question? Okay, next one. Because when you learn more and more, some characters look similar. Maybe it can cause you confusing in your head. Okay, we gradually move. Next one, the linear alba apocalypse. What is it? The linear mean like this เส้นตรงและ linear but be careful the linear it is spelling more R LINEA only because it comes from the Latin word that means white line. The linear above buccal is a horizontal, only horizontal strip on the inner surface of the sheet. And the important part is that the level of this line is along with the writing plane. If shown like this, but is the in the another level not along with the writing plane. You have to think about the other lesion. And it can extend from the most posterior to the corner of the mouth or just halfway or just 1/3 of the way. It depends in the person. And you see this one from the back to the anterior. It's white line. And because it's along with the occlusal plane, that means the cause that related with this line come from the pressure of the buccal mucosa to the occlusal plane and frictional irritation. So when some patient has a history of like a night riding habits, not that fun. A night riding habit maybe show the very prominent line than the others patient. Or someone chew only one side, maybe this more evidence than another side. Or someone has only one side of teeth, another side is no teeth. Maybe this only appear on only one side because it's related with the friction. So if you see like this, you just tell the patient it's just frictional paralysis from the friction. So you don't need to do any treatment. Okay. Next one, I move to the geographic time. Okay. The geographic time ภาษาไทยคือลิ้นแผนที่เนาะ geographic time I will explain again I think I already mentioned a little from my previous lecture another name is someone called benign migratory bursitis or erythema migrans lingui what is this when it show is red and white can you see from the picture is the red come from the depapillation of the epithelium on this area. The white border, the really thick white border is from elongation of the papilla or the epithelium. These two phenomena change from area to area. Some report day by day. And the shape irregular, so that's why they call geographic time. They don't know about the cause why it has to become like this. Someone think about the familial relation, but not in every case. So they still say that is still unknown cause. And most cases are seen in the middle age. That's why maybe younger people not come to you early, but most of them are in middle age. On my example picture, you can see different character, right? But the main character is that you have to notice of the red area, irregular shape, and surrounded by the white border. This also the lower, the red area surrounded by the white border. That means the focal red depapillation border by the related white or yellow margin. And this lesion often occur with the fissure tongue. When you see the patient with the fissure tongue, maybe you can see geographic tongue together. This is also another picture of the example of the geographic tongue. This card, this red and beautiful white margin. Most of the cases should appear on the dorsum of the tongue, but ventral and the other area also involved. Most of case should be asymptomatic because it's normal variation. But if you notice about when it show the red area of the depapillation, that means the epithelium is thinner than normal. So someone can complain about when they have a spicy or acidic food, maybe a little, how to say, a little pain or some like irritated feeling, but not severe pain or the painful feeling, just a little not normal feeling. But most of the case not feel any change from the normal. Okay, this is also another example of the red areas around the auricular white. Sure, it looks awful, but if you understand this character, and some patient can report that, yes, I used to notice previously it's located on here, another day it's located on here, and sometimes disappear, my tongue look normal. And but one day it's return again. That means the character has come and go and can change the shape day by day. It's confirmed that it should be geographic time. But if you are not sure, maybe you record with the photo and then maybe 2 weeks you can 2 weeks we follow up again. If it change and look like similar character, it change location 2 or 3 times, you can make sure for your confidence that it's geographic time. You can explain to the patient. No need to do any treatment, just reassure. Okay. That's all of the group of normal lesions that show the red and white color. Is there any question? Is there any point that you feel confused? But I think it's so easy group for because it's normal lesion. Okay, if no question, and we move to the next group, the group of the infectious lesion. This group, what is it? Infectious, that means some infection, maybe fungal, viral, bacterial. I will explain by one. Start with the oral hairy leukoplakia. Oral and hairy and leukoplakia. So from this word, can you guess about the character of this lesion? Okay, anyone try to join talking to stop you from sleepy. About the character of oral and hairy and leukoplakia. ช่วยตอบหน่อยนะคะ oral hairy leukoplakia
เป็นปืนขาวๆครับ
and how about hairy hairy แปลว่าอะไร hairy
อาจจะมีขนเหรอครับ
โอเคดูซิปื้นขาวแล้วมันจะมีขนไหมโอเค let's see together oral hairy leukoplakia. This is very important of the infectious lesion because it's an important manifestation of the HIV infection. So when you suspect the patient that has a character lesion like this and look like oral hairy leukoplakia, you should turn back to review the patient about medical history. Most of case may be denied. I am healthy, I'm strong, but they don't want to tell you about they have HIV infected person or someone don't know. There's clear that I don't know. Maybe they don't know that they carry the HIV. So this is important character. When you see the picture, oral sure for all hairy like this is a white line, it's like a hair, but it show the vertical white line packed very closely. So This vertical cannot be wiped off, cannot be scraped off, and symmetry to the both sides because it's a oral hairy case group of infectious lesions. So the infection opportunistic by EBV or Epstein-Barr virus, this virus, that means this patient are weak. That's why it show this character. And most of the person has a HIV infection. The hairy, like a vertical white line, the main character, vertical white line, this one. And when it look very close, you can imagine about the barcode that the vertical white line packed very closely. This one from the picture, the vertical white line. The lower one also had a vertical, but they packed very closely. This is just an example that difficult to discriminate from the leukoplakia because it's packed very thick. But when you see in detail, some areas look like vertical white line. So most cases classically show on the bilateral side of tongue. You can check for the two sides, both side left and right, and cannot be wiped off. Sure, patient no pain, no anything. Maybe they don't know, oh, that my tongue become like this. This one, vertical. See closely again, it looks like a barcode, right? Vertical, pack very closely. And you can try to wipe, it cannot be wiped. Because important, because when you talk about the HIV infection, and what is the difference about the AIDS? The AIDS is the end stage, right, of HIV. That means even patient has an HIV infection, but their status is not so good when they show lesion like this, because not so far or not so long they will develop to the AIDS state, like this one. Another example of the vertical white line packed very closely and look like leukoplakia. Because some reports said about 10% patient has 10% had the AIDS at the time of the diagnosis. When they see the oral leukoplakia and check the patient health status, not only HIV but 10% of the case are AIDS, already AIDS state. And 20% develop AIDS in the following year, and 50% in the 1.5 year, and 80% within the 2.5 year. That means the status of patient is not so strong. So very important that you can discriminate or notice about violation at the lateral of the tongue and think about the oral hairy leukoplakia. Sure, diagnosis. Not only character to confirm, you need to do the biopsy. The biopsy, you show the histone is a quite mosaicite like cell, like this. In the precursor rate, this is a character to diagnosis that oral hairy leukoplakia. However, before you start, or in general, sure you cannot do the biopsy by yourself. You can refer to do the biopsy. But in general practice, if we are suspect about HIV infection or status of the patient, we will not do the biopsy suddenly to check, consult the physician about the status of the problem first, and then try to plan a schedule for the biopsy later. This is another clear example of the picture that's a vertical white line. Okay. If the patient are stronger, like they are HIV and they receive the drug, like to treat the HIV, like HAART group, when the immune is better, this lesion will disappear by itself. Don't need to do anything. But some they try to use the anti-herpetic drug, that means some antiviral, but it's not directly with this disease. So they don't recommend to use this one because it has a risk of the resistance. So just diagnose and try to find out the health status of the patient and refer them to need for treatment in the if they receive the hard group of the medication, they will good respond and disappear. No any relation with the malignant and some immunocompetent or strong patient they report that can see this lesion as well, but they disappear by itself or spontaneously disappear. No need for treatment. Okay, that is about the oral hair recombination. Is there any question? Madam, no? Okay, next one. I think it is very common. Once in your life, you have to see this one. Oral candidiasis. This lesion can show different character in the clinic. And the most character are called pseudomembranous candidiasis and erythematous candidiasis. However, this common character, if it appears suddenly, like a short time within 2 weeks, we call acute phase. But if it's prolonged, appear for several weeks or months, it's called chronic. However, in the group of the chronic, there is one character called chronic hyperplastic candidiasis. And another group of candidiasis just for the candida associated lesion because maybe not 100% of these lesions relate with candida, but most of them relate. That is dangerous notitis, angular cheilitis, and median lumbar bursitis. Okay, I will explain each one. However, the word oral candidiasis, another word, some reference use the oral candidosis also used as well. It's not wrong spelling. In some era, they talk about the importance of the candida species because most cases of the HIV patient show the oral candidiasis because the HIV patient are weak, so they can easily infect with also virus, bacteria, or candida. And however, not only the HIV patient, the normal patient, but has the other environment that's suitable for the candida to overgrow. Also, there has an opportunistic infection in the ecology chain or immune defense cell. The most the candida albicans. This is the main cause because the candida has a various species. Another species like a mentioned but not common like a Candida tropicalis, Candida carbata, and another ones. However, the most important is the Candida albicans. And I think when you do the lab micro, did you try to do like a Candida swab or culture in the microbiology lab and check for the Candida carrier? Did you pass that lab? Experience that already? ได้ทำไหมคะแลบไมโคร
ได้ทำค่ะ
ก็มีใครเป็น carrier ไหมมีเป็นได้เอาตัวไหมคะไม่เอ่ย
มีครับมีครับ
Okay, so it's better to understand when you pass that lab, you can understand that okay, Candida also stay together like a carrier, not cause the disease in some patients. But when it's overgrowth to show the change in the mucosa, it's caused the lesion. So the candidiasis is a state that when Candida albicans cause the lesion. And when it show the white and the red character of the candidiasis, when the white lesion we call the pseudomembranous candidiasis or the trash or the candidal leukoplakia. At that stage, the hyphal or hyphae form are the common. But when it shows the red color of the lesion, like erythematous candidiasis, ventral medial lumbar cytosis that show the character of the red character, the yeast form are predominant. Sure, for candidiasis is that a factor, like a local factor influencing the oral immunity, ecology, systemic immune defect, and a combination of many factors. When you see the patient and you know it should be oral candidiasis, it's not difficult to diagnose, I think, in the clinical character. But the more important thing, you have to find the factor, because if you cannot get rid of the factor, the lesion will recur again and again. Like a first factor is about the xerostomy or dry mouth, because if someone has a dry mouth, can anyone help me to answer what is the possible cause of the dry mouth that influence to increase the number of the candida? What is the mechanism or what is the reason why dry mouth related with the candidiasis? You can guess it. I'm not need to the every right answer and try to think together.
เหมือนน้ำลายมีพวกแบบ anti microbial agent หรือเปล่าคะพวกโปรตีนหรืออะไรแล้วก็แบบ
เก่ง
เคลื
มาก
อน
มีอะไรเอ่ย มี secretory อะไรเอ่ย
อ๋อ SIGA ป่ะคะ
secretory IgA เนาะ so พอน้ำลายลดลง อันนี้ก็ลดลงแล้วก็จะสู้ไปน้อยลงมีเหตุผลอื่นอีกไหมใครช่วยเพื่อนอีกไหม another reason why dry mouth related with candidiasis อะไรเอ่ย โอเคไม่ได้เป็นไรโอเคก็คือ another reason is flushing because you have a lot of water in your mouth from the normal saliva is flushing, so the something that stick on the surface will be flush, but less amount of the saliva, this flushing disappear, so it's easy to overflow of the candida. And another cause like smoking, corticosteroid. The corticosteroid for sure that any local or systemic is depress the immune system, so any infectious lesion can overflow. And how about the broad spectrum antimicrobial or antibiotic? I mean they kill the bacteria, so the balance of bacteria and fungal loss. That means bacteria less, maybe fungal can be overflowed. And another cytotoxic chemotherapy, that means the cell destroy a lot, not strong. The candida can penetrate easier. Radiation involving the mouth and salivary gland. The radiation can cause the dryness of the mucosa from the salivary gland will be destroyed on that area. And following like with the xerostomy and then the same reason. And another dental appliance like a denture or retainer, also the reservoir of the germ or the fungal. Another reason about the systemic immune defect, like a malnutrition, also has a mechanical, but I will not explain the mechanism, but it's has a mechanism to make the effect of the immune system. And you can see like the patient has anemia from malnutrition of the iron can has an overgrowth of the candida or recur again and again. Another type, like a patient take immunosuppressant like a corticosteroid, or patient has a T lymphocyte defect from HIV infection, from the leukemia, and from the lymphoma or cancer, also easy to has a candidiasis. Or who has a diabetes, that means the neutrophil lymphocyte defect happens. Also factors. So one patient can has many factors like a dry mouth together with taking antibiotic. You have to try to ask about all of the factors to get rid of the factor in the perfect treatment. Next, we'll explain about the character of pseudomembranous candidiasis. The pseudomembranous, can you see, it looks like a creamy, like a yogurt spread on the surface of the mucosa. And if you notice, it come together with the mucosa that look a little red or more red, is depend. Red surface, but creamy on top, sometimes called crust or sometimes called acute antibiotic stomatitis. The weak person like an infant or the elderly commonly affected. If acute form may be come from antibiotic, immunosuppressant or disease that suppress the immune system. And this one, sure, they must be scraped off or wiped off if you use the gauze, set of that. And it leave the red surface, or sometimes if you scrape too strong, it's a little bleeding. And the pseudomembrane composed of the fungal organism, keratotic roots, inflammatory cell, desquamated epithelial cell, bacteria, and fibrin. And this show some area, not only the buccal mucosa, they can involve entire oral mucosa, like a soft palate, the porcelain part of tongue. In the case of the soft palate in the porcelain, you have to think about patient. Most of them use the inhaler of the steroid when they have the steroid inhaler. You have to ask about that as well. Asthma, that they use or not. If they use, they have a chance to recur again and again of the in the deep throat of the candidiasis. So you have to recommend to rinse every time after use the steroid inhaler. And another chronic form, maybe not only from steroid inhaler, maybe from the radiation, chemotherapy, or HIV infection person. Okay, next one, the character of the erythematous candidiasis. Erythema is mean red, so candida is show the red character. Another name, sometimes called trophic oral candidiasis, antibiotic stomatitis, antibiotic glossitis. The red easy to see from the tongue. That means the tongue depapillation, the million there, depapillation, glossy appearance, no papilla. Sometimes involve some parts, sometimes involve entire or overall tongue. Most of cases complain of burning sensation together on the tongue, on the bottom size depend. And the border is difficult complain to the normal mucosa. But if they have a sharp margin or sharp border, you have to think about erythroplakia than the erythematous candidiasis. And sure factor is that it is similar to the pseudomembranous form. This is cancer, yellow, smoking, prostrate, antibiotic, and other causes. And not only the tongue, the palate, some of tongue also show this lesion. However, the tongue, the chain mechanical is a depapillation and dekeratinization. That's why it's become the red and smooth surface color. The acute or chronic form present identical clinical feature both erythematous or pseudomembranous candidiasis. It just depends on the time that's onset. Okay, next we'll talk about the treatment. Because it's a common oral lesion that you can see, So I will mention some about the treatment, but to these candidates, we need to use the antifungal. The common use of antifungal like a nystatin oral suspension, 100,000 units per ml, meclizole oral gel 2%, and another is a clotremazole oral tube 10 milligrams. Even any type of the antifungal, the duration of use you must prescribe at least 2 weeks first and then follow up because it's difficult to kill the fungal and the fungal penetrate to the epithelium layer, so it takes time to kill it, and the frequency for the treatment dose, the best is a 3 to 4 times per day and at least 2 weeks, and then you follow up. If patient can use very best using and 2 weeks come very clear, lesion disappear 100%. We call the clinical cure. After 2 weeks, patient come and everything become look like normal or clinical cure. You need to prescribe another 2 weeks for biological cure because, like I told you, the epithelium are invaded by the fungal. So when epithelium you change, it takes time. If you stop suddenly after 2 weeks, the recurrence will come very fast. So they recommend the best way is at least 2 weeks. If it disappear 100% or we call clinical cure, we need to prescribe another 2 weeks for the biological cure. However, some patients cannot use the drug as we prescribe. We need 4 times a day. Maybe they can use 1 or 2 times a day. After 2 weeks, they can maybe just reduce the redness, but still have the red area or the white plaque reduce, but not disappear 100%. Just show the improvement, not clinical cure. So what should you do? If no clinical cure, just improvement. So what should we do? นะคะเดา
อาจจะให้ทาต่อไปอีกสักพักหรือไม่ก็กินยาครับ
โอเคขอบคุณค่ะพี่ตอบokay, after 2 weeks time, it just a little improve or some improvement, not cure. So the the way of treatment, you have to still continue every 2 weeks until it's complete cure. That means you have to solve the problem that just a little improve come from what? Maybe come from patient cannot use like we prescribe. We need 4 times, they just need 1 or 2 times. We have to explain again and let them to use properly. But some patient has not a strong person, that maybe HIV infected person or some disease that cause the immune is not so good. The medication just help some, but the immune weak disappear. That means the patient okay strong enough. But if not improve within 2 weeks, not completely, maybe come from another factor like patient weakness or cannot use, you have to continue every 2 weeks until it's completely healed. Some patient need 1 month, some patient need 2 months, 3 months. It depends on status of the patient. After finish or until completely healed, like 1 month, for example, you continue again for another 2 weeks for the medical care. So this is a step for treatment with the antifungal. However, for some immunocompromised patient, maybe they need a systemic antifungal. Systemic antifungal is better to prescribe by the doctor or physician because it has some side effect that maybe you cannot consider or aware enough. For example, they can prescribe fluconazole or ketoconazole. Next one, I will explain each drug, how to use it. The nystatin oral suspension. Because it's suspension, that means you need to shake, ask patient to shake before using. And they have the dropper to draw the medication, like the level of 1 ml. But each time to use, it's better to use within 1 to 3 ml. But when you get only 1 ml, maybe you very small amount, they cannot switch in the mouth because it's in the suspension. We want them to switch moving in the mouth, so maybe 2 or 3 ml is better to prescribe each time. But they used to switch 3 to 4 times a day for treatment. So you have to think about antifungal activity and nausea, vomiting with the high dose. This drug, patient can swallow because they write in the inside of the box that they can swallow. But if we want to treat only in the mouth, you can ask patient to spit out, switch maybe 3 to 5 minutes. Takes time, it's contact time, we need contact time, and then spit out. After spit out, ask them to don't drink any water suddenly because they will remove the medication suddenly. So rinse or switch in the mouth about 3 to 5 minutes and then spit out. And need this action 3 to 4 times a day and continue at least 2 weeks and then follow up. This is the way of using the suspension, nystatin oral suspension. So when the patient had a lesion overall in the mucosa, this action is better, right? Because it's water and can switch and move overall. And the next one, another choice of micronazole oral gel 2%. This is gel, it's not very thick gel. Gel is like a little watery gel. So one you can prescribe to apply to the area of the candidiasis if they're not covered in general or overall of the oral mucosa. But sometimes you live in the area that don't have nystatin oral suspension, but patient get the lesion overall the mouth. So what should we do? In this pack, there has a spoon together. This spoon. You can prescribe about half teaspoon and put in the mouth. When it's mixed with the saliva, it can move like a little swishing, not better equal as not good equal as the nystatin, but it can swish. And same thing, 3 to 4 times a day and at least 2 weeks. But this medication, they contain antifungal and antibacterial activity. And be careful they interact with the anticoagulant like warfarin and others, and avoid the pregnancy and warfarin. And the last common used one, but I think we don't prescribe a lot when compared to the physician because this comes in the tablet we call clotrimazole troche. You put in the mouth like a candy and let it dissolve in the mouth. But this need 5 times a day. It's not practical to use. And at least 2 weeks, the same thing. This is also contain antifungal and antibacterial activity. It's mild local effect and has anti-staphylococcal activity. Okay, that's all about the treatment of the pseudomembranous and erythematous candidiasis. Next one, I will talk about the chronic hyperplastic candidiasis. The chronic hyperplastic candidiasis is very rare in your lifestyle. Less tend to see this lesion. Another name they call candidal leukoplakia because it looks like speckled leukoplakia or erythroleukoplakia. Can you see in the picture the white plaque and the red surface? When you try to scrape, it cannot be scraped off. It's not similar to the pseudomembrane type. So it's difficult to distinguish from the leukoplakia. So how to diagnose? We need biopsy. Okay, so it shows the smooth or rough thick surface texture with erythematous background. And this is another example of white plaque and the red area. White plaque and the red area. It looks like erythroleukoplakia. So it's difficult to distinguish. Only one way is a biopsy. And even if the chronic hyperplastic candidiasis is a type of candidiasis, is important because this lesion can associate with the malignant transformation. So it looks like erythroleukoplakia that also relate with the malignant transformation. So if you suspect, it's good or better to send patient for the biopsy. And the usual size is a dorsum of tongue and the buccal mucosa, but post to commissural, they call post commissural buccal mucosa. That's how they call the chronic hyperplastic because when biopsy and do the PAS periodic acid sheet, they will show candidohyphae in the epithelium. And some case can see with the dysplasia. So because it's a chronic hyperplastic, antifungal also important, but only topical not enough. They need a systemic antifungal drug for several months. And similar to another candida, you need to eliminate the cause that like rama or another cause of the patient to prevent the recur. But this case, this lesion also often to recur. Even it has a potential malignant change, but it's low potential for malignant change. Okay, is there any question? Nina? Okay, next, I will talk about another group. It's called Candida-associated lesions. In this group, I will talk about dental stomatitis, ampullaritis, and medial lombard bursitis. Dental stomatitis, I think it's very easy to see this one because if patient don't have denture, please don't diagnose this one. Patient must wear denture. The they can happen in the palatal mucosa or the mandibular mucosa, but most common is the palatal mucosa because it's a huge area of the contact and the less amount of the cellular pool because the lower is most of case has a cellular pool in the floor of mouth. It's a flushing is better than the first. The contributing factor I think is like a not different from the another type, but it's not related with the denture. Like a poor prosthetic fit is losing denture as a formula. Or patient fail to remove denture at night. They try to live or sleep together with their denture. They don't want to take off. And poor denture healing, oral healing, these are the most contributing factor. And is friction of the complex of the candida and the bacteria together, infect together. They are classified to T-type by the Newton is a person name as well. Newton type 1, 2, 3. The Newton type 1 means that show the character of the pinpoint red area or pinpoint hyperemia. This type, most of the case caused by the trauma from denture, like a losing denture and they hit the surface, so they cause a type 1. But the type 2 and the type 3 commonly associated with the candida and bacterial infection. So when we see the dental stomatitis and we can classify it in type 2 and type 3, we can think about the treatment by using antifungal. The Newton type 2 is show the red area, not only pinpoint but entire over the huge area of the mucosa most of them along with the shape of the denture. And the type 3, not only the entire red area, but epithelium show the capillary hyperplasia. And you see it shows the picture. This is an example of type 1. Can you see the pinpoint hyperemia like this? But type 2, can you see is huge area of the redness. It's a red erythema patch. Show shape of the denture like this. Is a shape of horseshoe shape denture, right? This is also the denture shape, but this is not overall the area of the denture, but it's few area, not pinpoint. This is also the larger area than type 1. And this is a type 3, not only red. Can you see the surface? It's called papillated surface or papillary hyperplasia. You like a granular surface as well เหมือนกับเม็ดทรายนะคะที่ยกตัวขึ้นมานะคะเป็น papilla ออกกับผู้กระตุ้น this called the type 2. The treatment, like to you the type 2 and type 3 need antifungal. However, the other cause or factor like a control oral hygiene also important. Dental hygiene, oral hygiene. And if patient don't take off at night, you need to explain. You need to take off at night. Leave the denture out as much as possible. And when denture is losing, you need to rely or replace during the treatment because the losing can cause a trauma. And after you treat until it's completely healed, then you can start to do the new denture. And some case they are to come together with the dry mouth. Maybe the lubricant gel also reduce the friction from the trauma. Because type 2, type 3 relate with the fungal and bacterial infection. The best drug of choice is a micronazole oral gel because it's an antifungal and antibacterial property. But if you don't have micronazole, you can prescribe Nystatin as a suspension as well. The way of treatment similar to candidiasis. That means you need to use at least 3 to 4 times a day and at least 2-week follow-up. If it's complete cure or clinical cure, you need to prescribe another 2 weeks for biological cure. For using of the micronazole oral gel, you just ask patient to apply the gel over all the surface of the lesion, most of them on the palate, and then apply the gel on the surface of the denture. If patients still need to using their denture like a sandwich, that the medication are trapped between the surface of the denture and the tissue. But at bedtime, you ask patient to take off their denture. So patient just apply the medication to the area of the lesion as well. Not only the tissue that we treat, we need to disinfect the denture because this example, the candida can grow on the denture surface because the denture, most of them are the acrylic, and the acrylic has a porosity in the mathematical plate. It's a best reservoir for candida. So the treatment will also disinfect the denture. Most of them common use the chlorhexidine gluconate 0.12% หรือเราเรียกว่าปากคลอริดีนนะคะเช่นบีมาวอชหรือยี่ห้อเป็นที่มีตามท้องตลาด This is chlorhexidine. You used to soak the denture at night, and then in the morning you can rinse a lot, and patient can use to kill the infection both in the lesion and both in the denture. This is the best way to the treatment. Another disinfection of denture like alkali, hypochlorite, or denture soap solution like a benzoic acid. But most common is a chlorhexidine. And if you prescribe to patient to use a chlorhexidine and prescribe the Nystatin, just be careful that patient don't use together at the same time. Just leave the time to let them to not contact together because they remind about the concealing and statin complex. If they form the complex, they reduce the ability of both medication. But if you prescribe to you different kinds of drugs, that they mention about this complex. Okay. Next one, if you remember the type 3, when we treat the redness of the lesion, like a treat antifungal already, however, the surface of the papillary that hyperplasia is not disappear together. It still live like this, and it still become the reservoir. When you have the cleft like the finger, the cleft, the fungal will hiding in this cleft. So we need to get rid of the cleft by the cutting it off. The best cut is not come from the blade, but we call erectosurgery. Use the erective to remove. Just tell you to know the rough principle of the treatment. That is, after treat antifungal in type 3, we need to remove the rough surface out to prevent the reservoir or prevent the recur in the future. And after remove the hyperplastic tissue and the tissue heal completely, next you can start to do new denture for the patient. But in some case, patient like weak a lot cannot use topical antifungal and take very long time to improve. Maybe we have to consider about systemic antifungal as well in this case. Okay, is there any question? A lot of things to know, right? Okay, next one I will talk about the angular cheilitis. Angular คือมุมปากเสพนะคะ angular cheilitis, what is it? It's very easy to diagnose. We have to see the corner of the mouth of the patient. If the corner of the mouth look red or sometimes cracked or painful or some pus, that called the angular cheilitis. So most of patients like to lick their lip like this, or patient with the elderly is a drop of the corner of the mouth, and during the saliva accumulate at the corner of the mouth, it's easy to have the angular cheilitis. This infection group, that means come from the Candida together with the Staphylococcus aureus from the skin, because it's a skin area at the corner of the mouth. And 30% of the dental patient also have angular cheilitis. Maybe you have to see together in the mouth, in the corner of the mouth. And not every case feel pain, but most cases it has the red color. But each patient has also together or cross or crack together, they complain about the pain. This is show the mixing with the angular cheilitis with the oral candidiasis on the tongue. Main cause of the angular cheilitis come from the candidal infection together with the bacterial infection. But less case, if you see the patient with the angular cheilitis, maybe come from the vitamin B12 deficiency, iron deficiency, or loss of follicle dimension. That is less common cause, but most common are the fungal and bacterial infection. So the best choice of the treatment should be metronidazole gel 2% because it has an antifungal and antibacterial activity. And the same thing, use at least 3 to 4 times a day and at least 2 weeks. And for them, if clinical cure, give another 2 weeks for biological cure. Okay, next one, the median rhomboid glossitis. Okay, the median and rhomboid and glossitis. Who will explain the character of this word, median and rhomboid and glossitis? If you can understand the word maybe you can imagine about the lesion character ใครช่วยตอบหน่อยนะจ๊ะแก้มม่วงอยู่ไหมเอ่ยอธิบายหน่อย median and mobile prostatitis so what is the character
เป็นแบบการอักเสบที่ลิ้นอยู่กลางลิ้น
แล้วไงอีกแล้วลำบอย
บ่อย
ลำบอยแปลว่า
คางหมูป่ะคะ ใช่ไหม
อะไรลำบอยใครช่วยเพื่อนนะลำบอยต้องเป็นสี่เหลี่ยมอะไรสักอย่างนะได้ไหม
เอาเปียกปูนครับผม
โบนโอเคโอเคแล้วแปลว่าอะไรมีการอักเสบตรงกลางแล้วก็เป็นขนมเป็นปูนใช่ไหมถ้าตามขวดนะโอเคมา let's see together นะโอเคมีเรื่องน้ำมัน positive ใช่แบบนั้นไหมfrom this picture is median ตรงกลาง and rhomboid or not is pain if it's rhomboid isเป็นเปียกปูนsometimes oval shape or sometimes irregular shape as well but it's a middle or median so it's a erythematous lesion located in the center of the posterior part of the dorsum of the tongue. That is a definition of the median lumbar prostatitis. Is a one character of the erythematous lesion. That means the depopulation of this area. So, erythema, but its unique character is the posterior part and in the median. So we call median lumbar prostatitis. And most cases are symptomatic, but some cases complain about the burning sensation. And they need you to notice that when the tongue touches to the palate, maybe they reflect called the kissing lesion at the palatal area as well. Not only the tongue. So you need to observe the lesion in the palate together when you see the median lumbar prostatitis. Like this. So overall, it's like a little irregular shape, but still in the middle area. Sure, this lesion is a fungal infection, but they say that sometimes mixed with the bacteria. So the best medication should be meconiazole oral gel because they mix together with the antifungal and antibacterial activity. So I think the factor also is similar to the other type of fungal infection like a smoker, dental virus, or steroid inhaler. And no malignant transformation for sure, because just candida infection. And you need to think about reinforcing factor and antifungal agents. And the best antifungal, like I told you again, meconiazole oral gel 2%, because it's a good for antifungal and antibacterial. Okay, next group move from the candida is a measles or rubiola. What is this? This is rare lesion, very rare lesion, but it has a unique character, so I have to explain later. It's a viral infection caused by parvovirus or the measles virus. Rubiola, not rubella, ไม่ใช่หัดเยอรมันนี่เป็นหัดเฉยๆนะคะ It's like I think it's like another infection. When you get the viral infection, get the flu. Virus has an incubation period, has a prodromal period, and the virus will spread by airborne. So now it's uncommon because it's widespread of vaccination program. หัดเนอะออกหัดการออกหัดก็คือ they have a skin lesion before ออกหัด the skin lesion show the maculopapular rash affect head neck thoracic trunk and extremity จะสับเป็นผื่นเล็กๆนะแล้วก็ออกหัดไม่ได้หัดเดิมมันหัดเฉยๆ but when we focus the oral lesion before skin lesion oral lesion come first and before oral lesion they have a prodrome or prodromal symptom like a fever เหมือนเราเป็นหวัดนะ fever malaise on the pressure, like inflammation of the mucosa, running nose, nasal congestion, loss of smell, and sometimes conjunctivitis, photophobia, and coughing. How about the oral lesion? Is a pathognomonic character. That means another lesion will not show this character. They call the Koplik spot. Koplik เหมือนเม็ดเกลือเล็กๆๆ Koplik spot. That means the surface of the mucosa change to the red color and the small white spot. The small white spot come from the necrotic center of the tissue. Like เหมือนเม็ดเกลือเล็กๆ so they call Koplik spot. This is a pathognomonic character, unique character of the muscle in the oral mucosa. This appear just 1 or 2 days before the onset of the skin rash. So to diagnose based on the clinical sign and symptom, prodromal symptom, Koplik spot and rash. But the less common to use the lab to confirm. The treatment just supportive มันเป็นแบบ supportive treatment จะเป็นfluid adequate diet analgesic because it's infection of the virus มันเป็นแบบ can improve by ourselves if we are strong among healthy person. Okay, this is end of the second group. Next, do you want to take a break or want me to continue? ให้พักไหมจ๊ะพักครึ่งทาง
พักแป๊บหนึ่งก็ได้ค่ะอาจารย์
สักกี่นาทีดีลูกกี่นาทีดี5 นาทีพอไหม
5 ก็ได้ครับ
โอเคนะ ตอนนี้นาฬิกาประมาณครึ่งนะโอเค งั้นเดี๋ยวเบรก5 นาทีนะคะตอนนี้ตอน10 ครึ่งแล้ว13:15นะมาต่อกันโอเคจ้าเบรกได้ สวัสดีค่ะกลับมากันหรือยัง
ค่ะอาจารย์
เอาแล้วเนาะเดี๋ยวต่อไปเลยดีกว่านะเนื้อหาอีกเยอะแยะมากมายมหาศาลว่าจะเบรกตอนถึงประมาณครึ่งๆหรือเบรกไปก่อนครึ่งนะโอเคนะ โอเค let's go okay next group I will talk about the non-keratic white lesion that means the white lesion but not has a keratin or keratic so if you can guess it can be should be white or square or this group start with the habitual cheek and lip biting okay this one from the name is sure it's like a habitual like a habit and cheek and lip or sometimes tongue biting like a like to chewing cheek chewing tongue chewing lip all the time or very frequently so what will the result because the habitual cheek and lip biting or sometimes the habitual cheek lip and tongue biting depend on the area that they will chew like maybe they know themselves they don't know themselves unconscious if they chew the buccal mucosa another word called muscatio-buccarum if chew the labial mucosa called muscatio-labiorum and if they chew the lateral border of tongue called the muscatio-linguarum okay show the character of the white lesion that the erode surface because it's chronic you chew your tongue again or buccal mucosa again and again it's not so good it's come like this it's a rough surface and it's like a we call erosion because epithelium is lost some area and it's deep enough if you show a little bleeding it's not it's not completely to call the ulcer because epithelium lost some area not completely to or totally lost the epithelium so you can see some epithelium that เป็นลักษณะขุยๆนะคะเป็นลักษณะขุยๆภาษาไทยเป็นขุยๆรอบๆลุยๆนะคะอาจจะแบบหลุดเลือดออกมานิดหน่อยนะคะแต่ไม่ได้เช็ดออกเหมือนกับ pseudomonas canelensis เนาะ is racking the rough surface of the epithelium most of the cases are unconscious or straight or sometimes related with psychological disorder if they show a lot small area lesion show a lot small area if they show huge area they show huge area of the lesion so area of the chewing that relate with the lesion some patient chewing both sides some patient only one side this you can ask from the patient history and the prevalence not so much only 0.12 to 0.15 in Scandinavian population but some study in the mental health treatment facility the percent increase this is a rat desquamated epithelium erosion character so the common is buccal mucosa labial mucosa and tongue the operation just only superficial epithelium not deep into the connective tissue this is important character rough surface but some patients if they bite too deep some points may be shoulder also how to manage just explain the patient please stop chewing it's okay if not if patient can stop the lesion will gradually improve because our cell can have the power to heal to change the epithelium new epithelium count but if patients still bite again and again and again we need to do something like a night guard to wear on the occlusal surface to prevent the irritate to the mucosa and the other lesion that look similar like a white spot was chemical burn or candidiasis or social white character like this. So when you ask patient to stop chewing, maybe you can asked to follow up every 2 weeks that can you stop? You have this or not? You can stop. You can see the improvement of the epithelium. But most of the case cannot stop 100%. They just relieve gradually. Because most of them unconscious when they spread, they chew their mouth or their buccal mucosa. Okay, next one. I will talk about the burns of the oral mucosa. Burns mean chemical or heat as well. But most of case that I will talk is about chemical burn. The heat come from the like a patient eat a hot food and the heat burn, right? Or drink very hot food. A chemical injury or chemical burn come from what? Like aspirin, acetic acid from the dentist, acid, phenol from creosote, from butyl. Sodium hypochlorite, this is a dental material that we use, so who can cause the chemical burn. The most is a dentist. So the burns can cause a non-keratic white lesion that can be painful. Previously, the most common example is aspirin burns or acetylsalicylic acid because the old generation, when they have a painful tooth, they maybe not only how to say to take medication, but they put the medication on the local area. They hope that it will stop pain on that side together. So they put the tablet of the aspirin or the painkiller in the sulcus close to the painful tooth. So the contact of the tablet of the medication can cause a chemical burn at that area. This is example when leave the tablet, it show the peeling of the oral mucosa is become white and can peel นะคะ white pseudomembrane and painful area in the contact area of the chemical. The surface it is smooth and most of them are wrinkled นะคะ with or without necrosis. It depends. This is a example of acute area of the chemical burn, peeling of the white epithelium. Like sodium hypochlorite ก็คือน้ำยาล้างของรากฝัง that is also can cause a chemical burn. Okay. This is another example of aspirin burn. It's soft and can peel debris or necrotic tissue. This is another example of very large area of necrotic tissue caused by silver nitrate chemical burn. แต่เดี๋ยวนี้ไม่ใช่ใช้แล้วนะ commonly used silver nitrate, but just show the severity of the chemical burn. This is a common feeling of epithelium and burning sensation. So to manage, prevent is better. If you are the dentist who are going to do the root canal treatment and we need to use the sodium hypochlorite or any chemical agent, the use rubber dam is very important to prevent this lesion. And when it happens, sure stop that chemical and the epithelium will recover. However, during the waiting time, patient may be burns. So the protective agent to protect the epithelium surface, we use the dental adhesive paste. The common dental adhesive paste can prepare by the pharmacologist, but in the commercial, I found one. This is a so-called surreal. This is a trade name. Dental adhesive paste is a dental adhesive to cover or protect the surface to relieve the pain. So maybe prescribe to use 3 to 4 times a day until it's recovered. But in case of deep necrotic burn, this is more important. Need to debride to cut off the necrotic tissue and use the amoxicillin to rinse and follow up And sure, the antibiotic also important because when the heat ulcer, the secondary infection from our mouth like the bacterial super important. The antibiotic also important to prescribe together. This is the main way of the treatment of the burns of oral mucosa. Okay, for the next group is a corotic white lesion with no increased potential for oral cancer. First group can be or partially be wiped off, but this group cannot be wiped off because it's keratotic white. First one is a frictional keratosis. Friction is mean something rubbing or something irritate on that area. That means you have to find something friction, something to cause the irritation on the area of the lesion. So you can act as a frictional keratosis. If you cannot find any cause or any possible cause, then you should think about leukoplakia because its clinical character looks like leukoplakia is white plaque. Another name is a traumatic keratosis. It's a white patch or white plaque. That is a sharp margin, has a smooth or rough surface, okay. And you have to identify the source of the critical irritation. And the most common area is a area of the easy to irritate, like a lateral side of tongue, labial mucosa, buccal mucosa. For example, sharp edge tooth, lingual tooth, sometimes cheek bite, but not so strong, but a little bite again and again. Denture, like a denture flank, denture class, the corner, denture class, that is maybe irritate on that area or more position too. You have to identify these to diagnose like a functional keratosis. This is example of the edentulous area of number 3A area. You see the white plaque cannot be wiped off. If you suspect about the frictional keratosis, what is the possible irritation or possible cause? ไปได้ไหมคะว่า what is the possible cause for the frictional keratosis ในภาพนี้คิดว่า possible cause มาจากอะไรช่วยตัดหน่อยใครสมัครใจด้วยนะไม่อยากเรียกชื่อ
กัดกระพุ้งแก้มตัวเอง
ตรงนี้นะ edentulous
อ๋อ ฟันบนย้อยลงมากัดนะคะ
เก่งมากเนาะ you can guess that it's around this one no nothing but opposite side maybe tooth number 28 maybe supra eruption and bite on this area so if you can find this cause you can diagnose as frictional keratosis and the treatment you just remove the cause and see the improvement after 2 weeks the epithelium should be changed but it may be gradually changed. But if no change after you think it has caused, we already remove the cause. That means you have to think about the leukoplakia because we eliminate the cause but not respond. And biopsy also important at that time. So it's not difficult. Just find the cause, possible cause of that area. And if you eliminate the cause and it is improved, maybe not completely killed sudden within 2 weeks, but gradually improve is okay, but no improve need to do biopsy because it look very similar to the leukoplakia. Okay, next Merkel's keratosis. Next one. อันนี้ก็ต้องสูบบุหรี่นะ because it's for smokers keratosis. Another name like a smoker's palate, nicotine stomatitis, nicotina palata. Relate with smoker. This character look like this look awful. This maybe look like the cancer. Possible to have the cancer, but this is no any relate with the cancer of malignant chain. Lesion restrict to the area exposed to the smoker like a palate. So the area of the smoking from the heat from the chemical is a palate area. Okay. So if you see this is unique character, this is white plaque, and within the white plaque there are white papules, and in each white papule you see the red dot. at the center. The red dot at the center, this is a opening of the minor salivary gland. Its purpose is the inflammation of minor salivary gland from the chemical and heat. So we have a lot of minor salivary glands. So it shows the papu, and at the center is the inflammation of opening of the duct of minor salivary gland. สะดือที่จุดตรงกลางนะคะ That is a unique character of the smoker keratosis. If you see like this white plaque, papu, and at the center of the papu is red dot or the red center. This is a smoker keratosis. Even it look awful, but it's not related with any cancer. So just tell the patient, show in the mirror, and persuade them to stop smoking. After follow-up, maybe takes months or years, it will gradually disappear. ได้นะคะแล้วก็หายได้ Okay, I will skip the break. Next, I will go to the last group, potentially premalignant oral epithelial lesion. This name is the best name because this group change name again and again, but this name is too long. No, not popular to use. The previous one, PMD, potentially malignant disorders, more still popular. So in the more lecture, they still call the name PMD, potentially malignant disorder. This group mean any lesion in this group can have a chance to become a cancer. Start with leukoplakia. Leukoplakia ที่ our family in Thai is ฝ้าขาวไม่ทราบสาเหตุนะคะฝ้าขาวไม่ทราบสาเหตุกระเพาะไม่รู้จะหาเหตุผลอะไรว่ามันเป็นโรคไหน because the white patch or plaque that cannot be characterized clinically or pathologically as any other disease. So you cannot put it in the frictional process. You cannot put it to another name. So you put it to the word leukoplakia. There is no any associated cause, but except the use of the tobacco. From the picture, I think it's easy to diagnose that white plaque cannot be wiped off or scraped off sharp border. Any location can be seen. Idiopathic. Surface may be smooth or rough or thick or thin, it depends. And usually occur over 40 years of age. Frequency found in men. Preventive with age. The important factor tobacco สำคัญมาก Another factor alcohol and another factor is less common when compared to the tobacco and alcohol. The common side residue and mucosa more common than palate, gingiva and alveolar lip and lip, and more common than tongue, throat, mouth and vestibular area. However, the uncommon area are more dangerous because they say that the high risk side for the malignant transformation from the maximum to the minimum are the throat, mouth, tongue, lip, palate, mucosa, residue and vestibular. So it's contrast. Common side is not so dangerous, but uncommon side are more dangerous. So when you oral examination, that's why I ask you to lift the tongue, see the frog mouth, because if the lesion happen and you cannot find, but it's dangerous area, it's important to the life of the patient. Okay, they said about the important when they cut the lesion, that clinical diagnosis as a leukoplakia. The history report about 80% are hyperkeratosis, 12% are dysplasia, 3% are carcinoma in situ, and 5% are squamous cell carcinoma. That means all idiopathic leukoplakia may be transformation rate about 5 to 10%. But if they cut and found dysplasia together, transformation rate increase to 10 to 15%. This is a leukoplakia. And if you see the surface thick white cloth นะ you have to try to scrape or wipe it cannot be wiped off and you cannot character in another group you put the leukopenia and be careful to refer patient to do the biopsy is better. Most cases are sharp margin. There are also subtypes of the leukopenia: homogeneous leukopenia, nodular or speckled leukopenia, verrucous leukopenia, and proliferative verrucous leukopenia. Each one homogeneous leukopenia or thick leukopenia. That means the well-defined white patch of blood, sharp margin, cannot be wiped off. Smooth or rough surface or wrinkle is okay. The surface is depends. Sometimes look like a crack or mud-like surface. But if they call nodular or speckled leukopenia, that means the red color come to mix with the white color. They call erythroleukopenia, red and white. If red is more dangerous than compared to the only pure white. They are granular or non-homogeneous because they associate with the higher malignant transformation rate. This is also important. When you see the red and white, we call erythroleukopenia, more dangerous than leukopenia. And how about the verrucous leukopenia? The leukopenia that has a versiform, another name is versiform leukopenia. This is so fast, it's rough, it's thick, it's like verrucous, คุยๆยืดออกมานะคะ heavily keratinized นั่นเอง so sometimes look like an exophagic growth pattern. And how about the proliferative verrucous leukopenia? Is extensive capillary or verrucous white plaque นะคะเป็นกิน area กว้างเลย white plaque นะคะผิวก็จะเป็นขุยๆนะคล้ายๆนะแต่ว่ากินพื้นที่กว้าง huge area sometimes involve multiple area of the oral mucosa and this one important because it's very high risk for transformation to the dysplasia or squamous cell carcinoma or verrucous carcinoma. So if you see like it look awful and also it's also awful because transformation is higher. So you need to quickly to send for the biopsy. About the verrucous carcinoma, this carcinoma also overlaps a slow growing and well differentiated lesion that seldom metastasize. So it's I think maybe the dangerous when compared to the SCC is a less dangerous than SCC. Okay, this is a 4 type of the leukopenia, and the thing that emphasize we need to ask about smoking history to persuade patient to stop smoking. If patient stop smoking, this white lesion can be improved, maybe not 100% sure but improved, and the chance for the malignant change is decreased because patient stop smoking. We need to ask not only patient smoking habit but alcohol consumption because if patient also smoke and drink together, alcohol are promoter to synergistic effect to tobacco is more and more dangerous. So just not just ask about the smoking but alcohol consumption and ask patient to stop both of them. So for the leukopenia, can see from like I told you, from no dysplasia until my dysplasia until the squamous cell carcinoma. And how about treatment? They need a surgical extraction. If you do biopsy and no dysplasia, maybe just observe. But if they show the mild to moderate dysplasia or severe dysplasia, they need to be cut off. The way of treatment, in detail, the oral surgery department will teach you again. But this is just idea for the leukopenia. The treatment is to do biopsy and make decision to do the to remove surgical excision and stop habit for the smoking and alcohol consumption. Next, erythropenia ภาษาไทยคือรอยแดงไม่ทราบสาเหตุเนาะหาเหตุผลอะไรไม่ได้ของรอยแดงก็ นึกถึง erythropoiesia so the similar meaning to report that in the bright velvet plaque or patch which cannot be characterized clinically or pathologically as any other lesion we throw it to erythropoiesia but very less common difficult to see this lesion but if you see and suspect please hurry to do the biopsy because it's more dangerous than leukopenia very much red discharge margin because the prevalence of the high risk site similar is broad mouth tongue neutromolar mucosa subpalate gensula pilla high risk site for the premalignant chain why biopsy must be performed if you suspect about erythropoiesia must hurry to be performed because from the report of the histopathology 50% of the case of the erythropoiesia already become squamous cell carcinoma. 40% are severe dysplasia or carcinoma in situ, and just 10% just mild to moderate dysplasia, but no anything to be normal. So that was very dangerous. Hurry to refer to biopsy. Okay, next one. The group of the tobacco-associated lesion I will talk about smokeless tobacco lesion and pleural lesion in reverse smoker. Smokeless tobacco that means ไม่มีควันนะ smokeless ไม่มีควันนั้น tobacco ที่ไม่มีควันคือยาเส้นนะภาษาไทยคือยาเส้นนะคะที่เขาไปมวนไส้บุหรี่นะคะนั่นคือยาเส้นนะคะ Some patient think no ควัน no heat it's okay it's safe but it's not safe because it also contain the carcinogen นะคะ smokeless tobacco another name of the lesion like a smokeless tobacco induced keratosis snap pupil paralysis or tobacco pouch keratosis นะคะ Then the patient will put this in the mucosa นะคะก็คือเอาไปจุกไว้ on the sulcus area นะคะ area that they like นะคะ so when the smokeless tobacco contact to the mucosa is cause a irritation chemical so it is changed to the white color smooth or rough surface นะคะ but cannot be white off นะคะ it looks similar to chemical burn but not it can peel it off but this cannot peel off นะคะ cannot peel off most of them are not pain นะคะ this is example they put smokeless tobacco and after remove they show the wrinkle white dark นะ cannot be wiped off นะคะ and at the earlier stage maybe just white wrinkle mucosa very thin and then it show more thick and thick or granular surface นะคะ this is more mature เนาะ thick rough surface นะ tissue surface as well นะคะ so it's a group of malignant transformation so you have to be careful ask patient to stop using and follow up it should if stop it should improve gradually within 1 or 2 weeks show some improvement but if no improvement you need to do biopsy okay so next group is a pleural lesion in reverse smoker reverse smoker what is it opposite side that means สูบโดยอะไรดีไม่ใช่ตอบนี้ reverse smoker นะคะ reverse สูบอะไรดี reverse smoker ได้แล้วไม่ได้
อุดควันเข้าไปอะครับ
เอาด้านที่มีไฟอะเนาะด้านที่มีไฟเข้าในปากแล้วเรียก reverse smoker จะมีคนทำแบบนั้นหรือไม่ก็ต้องมีเนาะไม่งั้นจะไม่มีดิชั่นนี้นะคะตอนต้องดิชั่นมี reverse smoker so very rare นะคะเพราะว่ามันจะเป็นlesion that is some group of some group in the world นะคะ so they use habit to fire in put in the mouth นะคะ so dangerous นะ the chemical and heat นะ irritate all mucosa so the fire in they say that the heat the zone of air is a very high temperature, and some patients take 2 to 18 minutes to consumption. The heat in the cigarette can be reached 700 to 760 degrees Celsius, but intraoral may be heat up to 120 degrees Celsius, very hot. So all mucosa very burn from the heat and chemical. So the area that close contact to this is a palate and tongue that wrap this smoke or cigarette. So you can see various degree of the lesion like red area, ulceration, pigmentation, and white plaque. This is show the white plaque. This is show the pigmentation and the red area with the white plaque. This is character of the peritoneal lesion in the smoker. The history is depend. Maybe no dysplasia. Some report dysplasia. Report carcinoma in situ or squamous cell carcinoma. But very rare. But I need you to know that sometimes in the world we have lesion like this. This is the red and pigment and white plaque. This is a white plaque with the pigment. This is example. So Ramurusi and group report oral cancer about 2.4% in this group. And yeast might be considered as a cancer producing agent. See like this, needed for biopsy and smoking cessation. Okay, I think not difficult to understand. Next group, submucous fibrosis. Now from the word submucous, that means this lesion start under submucosa. Submucosa, and what is it composed? Composed of the fibrosis. If the submucous and fibrosis, you can guess the character. If fibrosis a lot, that means fibrosis a lot. For more fibrosis is more white and more firm นะคะยิ่งไฟบรัสมากยิ่งเฟิร์มยิ่งขาวมากนะคะ so this lesion is a slow progressive chronic disease นะคะ of the oral cavity by the fibroelastic chain and inflammation to the mucosa นะคะ leading to the progressive inability to open the mouth and swallow or speak because if the fibrosis a lot you can you imagine that okay your mouth will very stick together and difficult to open the mouth. If they cannot open the mouth, they can eat and drink and can bathe. So also important. This lesion of the coma can change for 4 to 8% of case. And this is an example for the locate on the soft palate. It's white and when you touch it, it's firm. Most areas are Southeast Asia, especially in the Indian subcontinent. This lesion very closely related to the butternut chewing หรือการเคี้ยวหมากนั่นเองก็เลยอยู่ในโซนเอเชีย Southeast Asia. This is example of the white submucosal band. The patient start with sometimes reports start first with the burning sensation in the mouth, especially with spicy food, and then some report the vesicle and ulcer, and next report about the difficulty to mouth opening because of a lot of fibrous formation. Difficult to swallow and speaking. This is in the tongue, right? Showing the palate. Patient cannot open mouth widely. Then they can involve vocal mucosa, soft palate, posterior pharynx, and tongue. Usually affect the young adult. So the factor, they don't know the real factor, but they think about the maybe nutritional deficiency, about some vitamin, or hypersensitivity to some diet like a chili pepper or patient chewing tobacco. But main report their factor is a betel nut or betel chewing คือการเคี้ยวหมากนะคะ American nut. This is example นะ new generation maybe you don't know about this นี่คือหมากนะลูกหมากนะคะลูกพลูนะเป็นใบพลูในใบพลูนะ they put this is limestone นะคะก็คือ ปูนแดงนะคะใส่เข้าไปยาเส้นด้วยนะแล้วก็ตัวหมักใส่เข้าไปแล้วก็เคี้ยวนะคะ These are carcinogen เนาะพอเคี้ยวนะคะก็คือ cause subcutaneous fibrosis nowadays the most patient found in the like Myanmar, because Myanmar love to have the little nut or little bit chewing habit. But Thai is maybe the old generation or some area found this lesion. It's not very common. But the treatment is very difficult when the patient has a small mouth opening. You have to ask them to exercise because they cannot open, they cannot eat or drink. If too much difficulty to open, we need some like an injection of steroid or some hyaluronidase to release, or some oral surgery to release the 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 mouth that cannot open. But after surgery, they also come together with how to say the fibrosis after surgery again. So the exercise also important. This lesion is the pre-malignant condition or potentially malignant disorder. Maybe transformation rate about 4 to 13% from some study. Okay, next one, actinic keratitis. Actinic mean can you guess actinic mean what? Actinic. Because it's not familiar word. But if you can remember the meaning, you can imagine to the lesion or the name of the lesion. ใครเดาได้ไหมคะ actinic แปลว่าอะไร actinic keratitis ใครที่ยังไม่เคยช่วยตอบส่งเสียงหน่อยอยู่ไหมเอ่ย
ไม่ทราบค่ะอาจารย์
อ๋อเหรอที่เงียบก็ไม่ทราบนะโอเคไม่เป็นไร actinic means sun ray solar นะคะเนาะ sometimes they call actinic keratosis solar keratosis or solar keratitis นะคะ so this lesion is keratitis คือตาอักเสบที่สัมพันธ์กับแสงอาทิตย์เนาะนะคะเพราะฉะนั้น the location is a vermilion area vermilion border vermilion zone because they contact to the sun ray the thing about the UV นะ UVB นะคะ the important thing and this lesion 10% undergo malignant transformation that's why it's important so the sun exposure that means the long-term exposure so you think about the patient that carrier that have to work under the sun exposure like a farmer or the fisherman or something like that so you see only the lesion involve the vermilion area. That means the word keratitis. And the thing the dark skin is less effect than the light skin because they have the melanin to prevent this lesion. And I will explain the character. The character may be composed of atrophic character or pale to silver gray, glossy appearance with various characters, often with a fine feature and wrinkle. They slightly firm, often swollen, and appearance of the lip. Possible present white or pigmented foci and poorly defined vermilion skin conduction or possible chronic ulceration in more severely damaged lip. This example, this is the crust and the red area come beyond the border, vermilion border. This is a swelling of the lip and red area and the crust. This is the ulcer, and with a little swelling and firm with palpation. This is red with the white area. This is a crack and red area. So important because it can undergo malignant transformation. If you see the lip with the ulcer and the sun exposure history and the lip when you palpation or touch it looks like a firm, but it should be soft. It's more dangerous. You should refer for the biopsy because it has a higher chance to malignant transformation. When patient report that they have chronic ulcer on the lip as well or the swollen palpation. But after biopsy is dependent, sometimes report only keratosis, only epithelial atrophy, sometimes report dysplasia or uh, uh, malignant or squamous cell carcinoma. This is the ethnic highlights. So what should we do? We should recommend patient to avoid expose to the sun like เปลี่ยนงานหลบแดดสมูกhat or something that prevent the sunlight นะคะ or they need to use the lip balm that contain the sunscreen like a cover นะคะ and some guy to growing the mustache to prevent the sun exposure and the more important is stop smoking because it's also simulate important factor to become malignant transformation. If do biopsy and they found something that abnormal, they need to do the bone minutectomy or cut it off or laser or many therapy treatment, but not emphasize on the treatment way. Okay, this is not very common lesion, but this is very common lesion in Thai. Oral lichen planus. I think you've heard from many lectures, but I have to emphasize it here. Oral lichen planus. Lichen planus is a lesion that can appear on the skin and in the oral together. If it appears in the oral, we call oral lichen planus. If it appears on the skin, we call only lichen planus. Is still unknown etiology is very important. If the patient asks what is the cause, we cannot say the cause because unknown etiology. And possible risk for the malignant transformation is about 0.4 to 2.5%. The mechanism, they say that cell-mediated immune system, that T lymphocytes come together a lot and these T lymphocytes try to destroy the epithelium. But why it destroy epithelium? They still don't know. That they say unknown etiology. There are many characters of lichen planus, but there's a unique form of the lichen. If you see this character, you should think about lichen. That is called the white striation or white striatum. เหมือนลักษณะเป็นรากแหเป็นลูกไม้นะคะ This is a unique character of the lichen planus นะคะ But the other form you can see the white that arranged like a reticular รากแห or circular or white show like a pattern or white plaque นะคะ or the red character of the lichen show like a trophic or erythematous show the erosive or ulcerative and can show like a vesicle or bulla. That is a rare type. But in one case, you can see not only white, but we mix together white and red or white and red and ulcer. This is various clinical features. This is an example. This is less show like a white striation, like a This is show reticular white mixed together with the red area. This is a white plaque on the tongue, and this is a red erythema or atrophic together with the white striation. This is show the white papule, and this is a red and white striation. This is kind of white plaque on the dorsum of tongue. This is the ulcer and ulcerated area and white striation. This example of the ulcer and white plaque, and this one example of the white striation, but the base is a red, and can you see the brown pigment or brown? We call the macule, Macule change only color, the brown or black macule. This is come from the hyperkeratosis. This is a unique term we call the post-inflammatory hyperpigmentation. เหมือนเราเป็นสิวพอสิวหายมันก็จะทิ้งรอยดำไว้นั่นคือ post-inflammatory hyperpigmentation. After we got acne here. This phenomenon can see together with a patient with lichen planus. Post-inflammatory hyperpigmentation. and in the gum you can see the red area beyond the marginal gingiva. We call this phenomenon as the desquamative gingivitis. One character of lichen planus can show like this one, atrophic or redness of the gum, called desquamative gingivitis. And next one, for the lower, this is example of the erosion of the epithelium. Okay, for example, this thumb is very huge, yellowish pseudomembranous ulcer. This is one form of the lichen. And small vesicle is one form of the vesicular type of the lichen. This is a very rare type, and most of them rupture very quickly and leave the ulcerated surface after rupture. And this lower picture show the atrophic or erythema mixed together with white striation. Okay, this is an example of the lichen planus. The common site of lichen planus is buccal mucosa, dorsal of thumb, and gingiva, and women more than men. Some report the association with hepatitis C virus infection. And for the white lesion alone, maybe asymptomatic, but when show the red or ulcer together, patient complain about the burning sensation. And the thing that to be careful is plaque type lichen is very similar to the leukoplakia, or if it mixed with the red, it's similar to erythroleukoplakia. You need to be careful about the differential diagnosis, and if you suspect, the biopsy is also important because plaque type or atrophic or erosive type have been reported about malignant transformation to the SCC more than another time. Lichen planus also has a skin lesion. The skin lesion, when you look at the skin of the patient, is for about 15% of the patient with oral lichen planus is a show the pruritic or erythematous or variolous papule เป็นเม็ดตุ่มๆตันม่วงๆชมพูๆ on top with the white striation and patient feel the itching feeling. The most common area is a flexor surface of the wrist. It's a characteristic side. Skin lesion of the lichen. This is an example of the skin lesion. Violaceous or pink papule on top, sometimes on top with the Wickham striatum. Another area of the lichen, it can fall on the genital area. The most in the women involve mucosa like a oral but genital mucosa. Patient may report about a burning pain when the vaginal discharge. But for the genital of the male, maybe they report about itching, purplish lesion at the tip of the penis, like a papule. And another area that you can see is a nail lesion. It's rare case, but nail show like it's which or splitting or cracking or loss of nail. This is a character of the nail lesion of the lichen. This is the example of nail of the lichen or splitting nail or dystrophy, the nail character. Okay, this is real keystone because lichen is a pathognomonic. When you do the biopsy, the pathologist can report that this lesion is a lichen planus because there is a character is important is a lymphocytic band infiltration under epithelium. Lymphocytic band is very important. And direct immunofluorescence can be confirmed diagnosis by they show the shaky band, shaky band of the fibrinogen as basement membrane zone or at the dermal junction. And some cases show the IgA staining positive right around small cell at colon body. But most cases show fibrinogen นะคะ chatty band at the non-visible junction of the skin membrane. So this is a histo of the direct immunofluorescence staining of the lichen. So the lichen is very similar to lichenoid lesion and lupus erythematosus, but the other is look a little different. But the very similar is the oral lichenoid lesion and lupus erythematosus. For the management, aim we want to eliminate atrophic and ulcerated lesion and relieve the symptom. And careful about the potentially decrease the risk of malignant transformation. In case of the white lesion only, they need no therapy, only observe and follow up because the lesion show only white, but one day they can show the red together, one day they can change to ulcer together. But when they come to the type of symptomatic type that contain the red or ulcerated lesion, the best thing to do, if possible, to do biopsy first to confirm diagnosis and to exclude the dysplasia and malignancy. And after biopsy, you have to think about the superimpose of the candida because some case report burning sensation. The erythema canesis can superimpose together with the lichen. And for the sharp edge or rough feeling, also irritate the lesion. Oral hygiene also important. And final, we need to use the medication. This is topical or systemic steroid in minus or plus antifungal agent if they have fungal together. And then follow up. We need to do the lifelong follow up because it's not a curable disease because we don't know the cause. The treatment just relieve the pain, relieve the symptom, but when stop the medication, the lesion recur again. And this is a in a group of malignant potential. So they have a chance to become the cancer. That's why patients have to come to follow up lifelong. The management after biopsy, the medication, the common we use the topical medication is enough, but in severe case that very acute ulcer or overall ulcer in the mouth, we need topical steroid together with the systemic steroid. But okay, systemic steroid is beyond the student that can prescribe, but topical we can prescribe. And the common use is fluocinolone acetonide 0.1% in oral pills. And it's a very high potency. The lower potency is called dexamethasone 0.1% in oral pills, and the less potency is a triamcinolone acetonide 0.1 oral pills. This triamcinolone is over the counter that patient can buy by themselves. This is also can buy by themselves, but fluocinolone acetonide is not commercial product. This product produced by Chulalongkorn University ก็คือฟลูออซิโนโลนคณะทันตแพทย์จุฬาเป็นผู้ผลิตนะคะก็คือต้องสั่งเข้ามาซื้อตามร้านขายยาไม่ได้ Okay, so this is again that reassure the patient. This is you need to long-term follow up and stop smoking and alcohol consumption together because it's a potentially malignant disorder. And for the treatment, use topical steroids depend maybe 2 times, 3 times, 4 times a day. It depends on the severity of the disease. But if you prescribe at least 2 weeks, you need to follow up. If you make the right diagnosis and give the right drug, the vision will improve. Not suddenly cure, but takes time for several months. And we have to follow up like every 2 weeks or months. It depends on the severity of the disease. But if you prescribe and follow up and the patient not respond like before, patient use the medication but vision not improve, you have to stop medication and biopsy again because maybe it can change to the malignant. Okay, next one. The lesion that look very similar to the lichen we call the lichenoid lesion. The lichenoid lesion is an OLP-like lesion. Everything looks similar to the lichen, like a clinical feature or histopathology. You cannot be simple. But lichenoid lesion has the cause. Lichen cannot have no any cause, unknown cause. But oral lichenoid has a cause. If the lichenoid drug reaction cause from drug, if we call lichenoid contact lesion, is caused from allergic reaction to the dental material. And if we call lichenoid reactions of graft versus host disease or GVHD, this come from the from the hematopoietic transplantation. I will explain each one. For the lichenoid drug reaction นะคะของโอเดียนะ is a drug induced นะ lichenoid reaction. So clinical again look everything similar to the lichen, but you have to ask about the association with the drug administration. Patient may report the taking the medication and then lesion appear after taking this medication, maybe some weeks, some months, or some patient can notice after years. So even it look very similar to lichen, but there is some unique character that are little different. That means the lichen is appears on both sides of the oral mucosa. Most of them are symmetry. Left and right look very similar. But if the lichenoid reaction, even it appear on both sides, but some side look more severe than another side, or some case happen only one side or unilateral side. This is some notice about a little different from the lichen. These are the name of the drug list that report that this name of the drug after patient takes is can generate the oral lichenoid drug reaction. This is a group of antimicrobial, antiparasitic, but most common is a group of antihypertensive drug นะหรือเป็นพวกยารักษาเบาหวานมาความดันนะคะหรือว่ายาพวกลดไขมันกลุ่มหลักๆมีนะนาเสเดนะแอนตี้ไฮเปอร์เทนซีฟแอนตี้lipid lowering agent นะคะ anti diabetics are the most common group to report about the oral lichenoid drug reaction. Okay, I give the name already. You can review later. And for the next group, oral lichenoid contact lesion, this name need the word contact. Contact that means you need the contact area. So you have to find the dental material like most of them are amalgam or amalgam filling that is a coral surface นะคะ or the rough surface นะ within the corrosion material can induce the delayed type or type 4 hypersensitivity reaction to the mucosa. So if you want to react the oral lichenoid contact lesion, you need to find a topographic relation or area that relate to the dental material that may be very close, very stick to the area or a little far away from the material. Not symmetry in general in overall, but only some area that show the relationship of the contact of the lesion to the dental material like a filling or crown. Not only amalgam, maybe composite also report about the oral lichenoid contact lesion. The most metal like a mercury, nickel also report about cause of the lichenoid contact lesion. This is example, and you see the old rough surface of amalgam filling and the lesion very closely related to this area and found only one area. So it should be oral lichenoid contact lesion. And how to treat? You just remove or change the type of the material that patient is not allergic with. And how to prove which material that patient had the allergy to them. They use the what called cutaneous patch tape. that may play a role in diagnosis. Patient is to use some dental material like silver, amalgam, or the gold or copper. That any material that can be the composition of dental material put in the bag of the patient, and then they leave about like the 24 hour and pull out to see the reaction, and they report that this patient allergic to mercury, this patient allergic to nickel. So you can make that data to compare that what material that patient contains. So that's why you need to learn about the dental material, because we need to know the dental material composition. And if there is allergy, you have to know this material contain what composition, and you have to change the new type of material. This is an example. After remove, they show the reaction of the swelling or redness area. This is concept of the retinal contact lesion. Find the contact area of the lesion with some material called crown or filling. And easy way is you can try to change material. If the overmountain, you can change to composite and then follow up. The lesion should be improved, maybe not 100% completely healed or completely healing, but most of them improve. But if you are not sure, you want to test what kind of material that patient allergy, because maybe patient is a gold crown, that's very precious material. If you remove, and if patient didn't allergic, we're allergic to that, patient will lose a lot of money. The way of to do the patch test. Also another choice, but the patch test cannot find in every hospital, because we need the unit of patch test for dental material. The area of the hospital that can provide like a dermatological institute หรือสถาบันโรคผิวหนังนะคะหรือว่าจะเป็นศิริราช hospital นะคะ for special request for patch test for dental material. This is the idea for oral retinal contact lesion. This is an example for the material, and after change to the composite, the lesion disappear. This is an example. But change is not very quick. Sometimes change many months until it's better. Sometimes years until it's better. Okay, the last group of the retinoid lesion is a retinoid reaction of graft versus loss disease or CHD. This is rare to see this group of the lesion, because the patient must do the allogeneic hematopoietic cell transplantation or SCT. Because not common patient to do this one, ปวดไข้กระดูก so it's rare to find this patient and come to you. However, if the patient has history of hematopoietic cell transplantation and have the oral lesion look like lichen, you should think about retinoid reaction of graft versus host disease. Because this is reaction come from the reject the tissue of the host. That's the recipient receive the bone marrow from the donor, but the donor bone marrow reject the tissue of the host and cause this reaction. The chronic graft versus host disease is defined as occurring more than about 3 months or 100 days post hematopoietic cell transplantation. So about 15 to 50%, or some report about 33 to 64%. And this is a example of the lesion. Is look like it is red or ulcer or the white line aspiration. And chronic graft versus host disease is not only oral lesion, but there is another lesion on the skin as well. in the oral, I will show that it looks very similar to the oral lichen planus. This is called the descriptive gingivitis. This is called the ulcer, white line, white striation, and red area, or toxic area. This is example of the oral lesion of the chronic graft-versus disease that look very similar to the lichen, white and red area with the ulcer. But this is just a skin lesion that is one composition of the graft-versus disease. This is a pruritic maculopapular rash on the skin. This is give you just idea that not only oral but skin lesion also happen in the graft-versus disease. So the treatment way of the oral is the same way as the lichen planus. Lichen, the same way of the treatment. And also is should be careful about the secondary malignant transformation. Okay, next one. The lesion that look similar to the oral lichen planus again, but rare when compared to the oral lichenoid lesion group. This group is the lupus erythematosus. The deep detail of the lupus erythematosus, I think you have to have a chance to learn again when you learn about the topic of the oral manifestation of the systemic disease. Okay, in this lecture I will talk roughly about the point that's important. Why is the look like lichen and what is a similar point and different point. Lupus is believed to be autoimmune disease involving both humoral and cell-mediated arm of the immune system. In fact, lupus is various subgroups, a lot of subtypes of the lupus, but the most common or well-recognized form is a systemic lupus erythematosus or SLE, and this called lupus erythematosus or DLE. That is a systemic is an acute form. This called is a chronic form. This is the most common, well known. That both type of the lupus has the oral manifestation and it looks very similar to the oral lichen planus. There are less aggressive form and predominant affect the skin, and there is a very progress. Even patient was said that with just DLE or this called lupus erythematosus, but 1 to 5% of patients may develop the systemic lupus erythematosus or SLE later in the future. So it's important. How about the SLE? SLE เนาะภาษาไทยคือโรคพุ่มพวงแต่ใครมีความรู้เกี่ยวกับ SLE บ้างว่าเป็นไงบ้างลองช่วยตอบนิดนึงค่ะ You know about the SLE, some knowledge. What is it and what is the main clinical character that you already used to heard or used to learn? ช่วยตอบหน่อยใกล้ง่วงใกล้จบละนิดเดียว SLE เป็นไงนึกออกไหมไปเรียนวิจารณ์เกี่ยวกับ SLE เป็นไอเดียไหมช่วยตอบกระจายหรือไม่เลย
ที่บนหน้าจะมีเป็นแบบบัตเตอร์ฟลายอะไรวะ
เก่งมากนะบัตเตอร์ฟลายแลชหรือมาล่าแลชเนาะนึกออกแสดงว่าเคยเรียนไหมเคยเรียนยัง
เคยแล้วค่ะ
เคยแล้วนะแต่นึกไม่ออกนะบอกว่านะเนาะ this is a ก็คือเป็นสิ่งที่เราจะต้องเอามาเชื่อมกันได้นะ the connection of the we learn the how to say cause of the general medicine cause to the basic knowledge of the disease and some disease have the oral manifestation. You have to link together because when you see the patient, you don't know that they show white striation, white line, red lesion is only lichen planus or patient contain the SLE or DLE because the dangerous to the patient are very different. If only lichen is not so serious, but if patient is a SLE is very serious because they can develop or affect to the other organs and can be like kidney disease. That's why dentist has to learn a lot. Only not mouth defect, but systemic body defect or the disease of the body. You have to link together. And I understand you learn a lot. You cannot think everything and link together. But this is some idea for today lecture that you have to try to connect together, synergies together from your another lecture. Okay. So for the LE, there are the heterogeneity of the lupus syndrome. This is just example that for the lupus, not only SLE, not only cutaneous LE or DLE, there's another like a refractive incomplete LE, childhood SLE, and phospholipid syndrome. These are little issue disease is a group of the lupus syndrome. Okay. And when you want to diagnose the word SLE, not only patient has an oral lesion with lichen, but there is a criteria. When you want to say this patient has SLE, it's not easy. You have to find the fitting criteria. This is an example of criteria 2012 because the criteria will be updated every year, I think. This is a previous common use the criteria. That means require more than 4 criteria. 4 or more than 4 criteria. If patient had a 4, at least 4, okay, then we can call patient has a SLE. For example, one of example is a chronic cutaneous lupus. This is one example. Or oral or nasal ulcer. This is oral or nasal ulcer that has character look like lichen. This is one character that we can link or lead patient to think about. Patient has a SLE or not. When want to diagnose, patient need one side of the lab positive and one side of the this lesion, but they have to pass together at least 4 positive that they call SLE. But nowadays is 2018 criteria. There's another new classification. I don't know in the future they change again or not. When patient want to be diagnosed as SLE, patient need to meet the point of each criteria in left side and right side, not enough, but they scoring the severity of each character. And patient need at least 10 points from the criteria to be diagnosed as SLE. This is just example for explain when someone has a criteria of SLE. This is example for the Malalas. You see this one, right? Your friend answered very good. And another thing like a pain at joint คือการปวดข้อ Malalas มี skin rash นะคะเป็นต้น but related with the dentist is a oral character that look like lichen. And how about the DLE, this called lupus, or cutaneous lupus, is we emphasize on skin lesion. The skin lesion most common in the sun exposure area like the face, ear, scalp, and the chest, back, extremity. And this is an example of the skin lesion of DLE. This is an area of the different color. The center are white, more white, and the red margin. This is a discoid rash. We call discoid rash. The skin lesion develop. Maybe it happen on the scalp. It cause a hair fall, no? Alopecia, no? And this is a oral mucosa. The oral mucosa, the lesion, like to is look like lichen and lichenoid lesion. But the thing is important. The common side of the lichen also bulbar mucosa tongue and gingiva is in the white color. But lupus lesion has a common side of the lupus that not same like a lichen and two area not same like lichen present on the palate and vermilion border. So when you see the patient has an oral lichen planus feature but lesion appear on the palate or vermilion border, you have to think about the differential diagnosis of the lupus erythematosus. But not in every case of the lichen you have to put the differential diagnosis of the lupus because the lupus is very rare case when compared to the lichen. So you have to find out about like a OCT lesion or discoid rash, or the patient has a malar rash, patient has a pain at joint, or patient has another systemic disease that can refer to the systemic manifestation of SLE. At that time, you can put the differential diagnosis to think about the lupus. Not in every case that you have to pack lupus together with the lichen when you put the differential diagnosis. You have to have the more reason. Another reason is a location that I need to emphasize again. The location, the common location of the lichen and the lupus is the same, mucosa, tongue, and gingiva. But common location of the lupus that not same as lichen is the palate and vermilion border. So when you see lesion in this area, you have to think about the lupus erythematosus as well. However, lichen also can happen on this area, but it's not common location for the lichen. Okay. Okay. For the another character that can a little discriminate lichen from the lupus, this is a character of the lesion that called radiated white line. That means, what is it? The radiated white line is the area of the redness or atrophy surround with the white line, but the white line radiate like a sun ray from the breast center. That is radiated white line. This is a unique character that's more common in the lupus than lichen. So if you see the character of radiated white line or radiating white striation, you have to think about lupus erythematosus in the differential diagnosis. But maybe you have to, you don't have to put 100% that this should be systemic lupus or discoid lupus because clinical character of systemic lupus or discoid lupus in the oral lesion look very similar. You don't know which is from discoid or which is from systemic. So maybe just put the lupus erythematosus in the differential diagnosis. Okay. Not only the radiated white line, the location is linked. Also important to think about lupus erythematosus. And origin of SLE are similar to those in PLE and present about 9 to 45 of the case of oral lichen. And this is another character of the lupus lesion in the oral. Not only look like white line, white striation of the lichen, but maybe they present like a honeycomb plaque or silver white square plaque, or red sclerotic plaque. But if you notice the example of the area that happen on the palate, this is common side of the lupus. Okay, another type maybe show the purpura petechia or regular shape ulcer also possible to one character of the oral lesion of the lupus as well. So histo is also can be distinguished between lichen and lupus. Because the most histo show the lymphocytic infiltration, but the different point is in the lymphocytic infiltration, then we show the subepithelial and perivascular distribution. That means the perivascular infiltrate of the lymphocyte will present in the lupus lesion. If perivascular infiltrate will not present in the lichen just lymphocyte band, but lupus has a perivascular infiltration of the lymphocyte นะคะ This is the different point นะคะ That's why histo can answer which is a lichen, which is a lupus. And another thing to help to distinguish between lichen and lupus, this is a direct immunofluorescence นะคะ The previous I told you that lichen planus is a lymphocyte DIF direct will show the fibrinogen positive at dermal epidermal junction like a shaggy band เป็น fibrinogen but lupus is show positive of IgG or IgM or IgA not fibrinogen at the dermal epidermal junction so the positive different antigen that lichen positive at fibrinogen but lupus positive at IgG, IgM or IgA or C2 but it's a shaggy band different positive of the antigen reaction and the differential diagnosis sure because it looks like lichen is like lichenoid so you can have the think about differential diagnosis of this one and the treatment also similar to the lichen even the topical steroid or the management way that the lifelong follow-up because these lesions are potentially malignant disorder also have a chance to become malignant even it's not so high percentage. Okay, this is a videography and this is the end of my lecture. Okay, ก็ขอบคุณนะคะที่ตั้งใจฟังตั้งใจเรียนมาถึงตอนนี้ก็ไม่รู้จะเหลือกี่คนใครมีคำถามอะไรไหมคะฟังจนเหนื่อยหมดสภาพแล้ว
อาจารย์ครับผมสงสัยว่าไอ้ไลเคนเพลนัสกับลูปัสอิริสติมาโตซัสเนี่ยครับ
จ้ะ
คือเวลาคนไข้มาเขาทั้งสองโรคอันนี้คือเวลาคนไข้มาหาเราส่วนใหญ่มันจะมีclinical symptom ที่ไม่ใช่ในปากตลอดเลยป่ะครับหรือว่ามันจะเจอในปากก่อน
ส่วนใหญ่นะจะเป็นในปากเป็นหลักนะสำหรับไลเคนนี่ก็ในปากเป็นหลักเลยน้อยมากที่จะเจอสกินลีชั่นร่วมด้วยเนาะไม่ว่าจะสกินลีชั่นเนลลีชั่นหรือเจเนทัลนะคะเพราะฉะนั้นเนี่ยก็คือการที่เราเจอเราสงสัยไลเคนแล้วเราก็ถามหรือมองหาสกินลีชั่นเนลลีชั่นก็คือเป็นตัวช่วยเสริมว่าเฮ้ยมันเป็นไลเคนแน่ๆนะคะแต่ว่ามันไม่คอมมอนที่จะเจอพวกนี้ประกอบในขณะที่ลูปัสเนี่ยก็คือแล้วแต่คือถ้าเคสที่เป็นแบบเพิ่งเป็นไม่มากเป็นไม่นานก็มักจะออรัลนะมักจะนำมาก่อนจะเจอออรัลอย่างเดียวก่อนแต่ถ้าเป็นเคสที่เป็นอยู่แล้วเป็นลูปัสเป็นเยอะๆเป็นมานานทรีตอยู่แล้วเนี่ยก็คือเขาก็จะให้เห็นว่าเรามีสกินเลชั่นให้เห็นด้วยนะคะจะมีอาการอื่นๆของซิสเตมิกเช่นมีมาลาแรชมีปวดตามข้อหรือว่าโรคอื่นๆทางซิสเตมิกที่เป็นองค์ประกอบของลูปัสมาด้วยนะคะเพราะฉะนั้นหน้าที่เราจะนอกจากดูในช่องปากเราก็ต้องหาองค์ประกอบอื่นเพื่อนำมาช่วยในการวิจัยเนาะมาซักประวัติตรงอื่นไหมตรงมีโรคประจำตัวอื่นด้วยไหมเผื่อจะเป็นซิสเตมิกอื่นเช่นเขาจะมีอะนีเมียร่วมด้วยในพวกที่เป็น SLE นะคะเป็นต้นแต่ปากจะคอมมอนมากวันนี้โอกาสที่จะเจอองค์ประกอบอื่นถือว่าน้อยแหละถือว่าน้อยนะคะเพราะนั่นแหละก็ต้องแอบจะเอาเราเป็นหลัก
โอเคครับขอบคุณครับ
มีการใส่ไปจ้ะเยอะมากยากมากปวดหัวไปหมดแล้วนี่ไม่เอ่ยโอเคถ้าไม่มีนะถ้าไม่มีแล้วเนาะไม่มีแล้วเนาะถ้าไม่มีอาจารย์ก็โอเคค่ะจบการเลคเชอร์ของวันนี้เท่านี้นะคะก็ขอขอบคุณทุกคนนะคะที่ตั้งใจเรียนนะคะแล้วก็ขอบคุณคนที่ช่วยคำถามกันต่อนะว่าเป็นแอคทิวิตี้ว่าถึงแม้ว่าจะเป็นเรียนออนไลน์ซึ่งมันจะช่วยคนค่อนข้างยากหน่อยก็ไม่ได้เห็นหน้าทุกคนตอนนี้ก็ขอให้ทุกคนก็ประสบความสำเร็จในการเรียนนะตั้งใจฟังแล้วความรู้ไปใช้ให้กับคนไข้ได้นะก็ให้ทำข้อสอบได้ด้วยนะแล้วก็เป็นคนไข้ที่ดีแล้วก็เดี๋ยวค่อยพบกันในเลคเชอร์ต่อไปขอบคุณมากค่ะ
ขอบคุณมากค่ะอาจารย์
ขอบคุณค่ะ
สวัสดีค่ะ
ขอบคุณค่ะอาจารย์
ค่ะ
สวัสดีครับ
สวัสดีค่ะ